Hey, Dr. Centeno, and thanks so much for joining us this morning. Today, I've got an interesting guest. We're going to be talking to a patient, Jennifer, who had a PICL procedure, but also really worked hard on brain retraining, neuroplasticity, to kind of rewire responses to the symptoms and the pain and all the rest of it. And it really helped her change her life, so much so that she has taken what she's learned through yoga, structural integration, and health coaching, and is really trying to put that together with this type of neuroplasticity brain retraining so that she can really start to help others through this journey. So welcome, Jennifer, and thank you for being here. I'm going to just sort of repeat that one more time so that as people join us here, again, I'm with Jennifer, who's a CCI patient. She has a background in structural integration, yoga, and other things. She got a PICL procedure and then felt that there was another piece she had to add, which was some neuroplasticity training. And so we're going to get into that today. I think this is important for patients because very much in CCI patients, there's the physical condition, and then there's sometimes the reaction to the condition that then can sort of spiral on its own and create lots and lots of additional issues for patients. So I think some of the messages that Jennifer has will be helpful for everybody. As usual, we'll do about 20 minutes of this, and then I'll get into answering any question. If you've got questions about this topic or really any topic, just put those in the comments wherever you are. If you're on Facebook, you're on YouTube. If you just put that in the comments, then I can see it. If you get it in the comments earlier rather than later, that's great because there's always 10, 20, 30 comments and questions I can't get to. So Jennifer, welcome in. Just tell people about yourself. Let's start with your background, not so much as a patient, but with who you were before you were a CCI patient. But I lost your voice feed there. We'll get it going here. Still don't hear you. So when Jennifer gets that sorted out, just letting everyone know that we're going to be talking about neuroplasticity today and how that interfaces with craniocervical instability. And if you've got some questions, just put those in the comments wherever you are located. Jennifer, do you want to drop out and then maybe click the link and come back in? Maybe that'll be good here. So let me do that. So again, going to be talking about neuroplasticity today, which is really how do you rewire the brain, and in particular for CCI patients, how do you rewire it in such a way that some of the input coming in, meaning the dizziness, the balance issues, the headaches, the vagus nerve type things. Let's get Jennifer back on here. Say something there, Jennifer. No, still no sound. Let's see here, maybe. Yeah, everything looks good on our end. Still not getting anything here. Let's see. While Jennifer works on that, let me start just getting to some questions here first. Then we'll kind of reverse it and get to some questions first. Let's see. The one, I've lost 15% of my muscle mass in the last 5 years, almost all of that loss in my neck and shoulders. Do you prescribe nandrolone or growth hormone if requested after a PICL to get faster rehab? There's really not a way to get faster rehab. I don't know that that's a thing, meaning that you just have to increase your activity in order to get stronger. So I don't think I'd be comfortable prescribing shortcuts, and I don't believe they'd work either, meaning that you've got to be able to get to the point where you can strengthen. That's obviously getting stability on the ligament side. That's also obviously calming down some of the parts and pieces that are causing symptoms, nerves, upper neck joints, etc. So I don't think I'd be comfortable prescribing those things. The one, is it true that CCI patients have excessively fast reflexes and that CCI patients often have low B12 levels? Excessively fast reflexes I haven't seen. If you mean they're hyperreflexic, which is different than fast reflex, they can be. That would usually mean that there's irritation of the high upper cervical spinal cord, and then that is causing a hyperreflexic or a bigger reflex, but not a faster reflex. And then CCI patients and low B12 levels haven't observed that. So let's see here. We got Jennifer. Let's see if we can make this work. Jennifer?
Yes, let's hope this works now.
Okay, yeah, that looks like it's going to work. Okay, so sorry about the technical difficulties, guys. We just needed to get Jennifer's audio sorted out. So Jennifer, tell us a little bit about yourself prior to CCI. What's your background?
Sure. So my background professionally is as a board certified structural integration body worker. And I had a 14-year career in body work as well as teaching yoga. And I was a super active person before everything. I was weightlifting 3 days a week, at the hot yoga studio 3 days a week, out hiking and doing all the things. And then life changed.
Yeah, so tell us about CCI and what happened there and what kind of symptoms you had. So yeah, tell us about when that began.
Sure. So between 2009 and 2013, I had numerous whiplash injuries, including multiple falls from horses in my horseback riding days, as well as I was a passenger in multiple car accidents. And it was also a combination of two of those within 25 hours that I also incurred a traumatic brain injury in 2013, and that upended my life as well. So, despite getting lots of great care and doing all of the quote right things, because after all, I was a holistic health professional, by 2017, things started to decline. My energy gradually got less and less to the point that by the fall of 2019, I was barely able to get it off of the couch and I was really debilitated by chronic fatigue syndrome. And then I also had to close my practice by early 2020. Actually, before the pandemic, I closed my practice and ended my 14-year career and had to go through the whole disability process and go on disability. And I also developed dysautonomia, specifically postural orthostatic tachycardia syndrome, also known as POTS. And I didn't understand really like why I would get lightheaded just sitting, let alone doing any activity. Why my feet would turn purple if I sat or stood, or even after the shower. I could barely sit or stand for very long at all after that. And nothing seemed to help, regardless of who I saw or what I did. And by 2020, brain fog made it also really, really difficult to be functional. And really at 36, when I closed my practice, I thought my life was basically over and that I was doomed to be on the couch in my sweats for the rest of my life. And I didn't even hear about CCI until 2022, and it actually wasn't from any of my providers.
Yeah. So, yeah, tell me about how did you figure out that you probably had CCI, and then how'd you get from there to getting a PICL procedure?
Well, ironically, I was actually getting physical therapy for something else completely unrelated. And I was experiencing these symptoms of getting a lot of pressure in my head. And I asked my dysautonomia Facebook group if that could be related to dysautonomia or maybe it was related to the brain injury. And someone said, that sounds like craniocervical instability. And I had seen that term thrown around a couple times, but I looked it up. And the more I did, I was like, oh, given my history, that makes a whole lot of sense. And I did a little bit more research and I found the Centeno-Schultz clinic. And because it made so much sense, I thought, at this point, I'm at rock bottom. I have nothing to lose. And spoke with my husband about it. We budgeted for it and like, let's do it. Let's give it a try.
And then, yeah, so uh, tell me about your PICL and then what happens after that and how did the recovery go and all of that stuff.
Well, after pickle number one, I call it pickle.
Sure.
It took almost exactly 6 months for me to notice improvement. Unfortunately, I want to point out this is extremely rare, just a side effect because of the antibiotic given. I just had tremendous gut issues that lingered and persisted. And so that interfered, I think, and slowed down my healing process a bit because I had two things to recover from rather than just one. But it was St. Patrick's Day weekend, and I was going to do a little bit of yard work, expecting to have a post exertional malaise, aka a crash, for 3 days after, as was typical at the time. And the crash never came. And it has never happened since. And so at that about 6 month mark exactly, I no longer had chronic fatigue syndrome. And overall, I had less neck pain and brain fog. That was definitely improved. But I still had some dysautonomia and POTS symptoms lingering. So then I decided to pursue a second pickle 14 months later. And since that one, my chiropractic adjustments with my AO have generally held better, and my dysautonomia and POTS symptoms are virtually gone, thanks to the combo of both two pickles and DNRS.
Yeah, so now let's get into the DNRS. What is that? Um, and just tell people, how did you chance upon this? Is it something that you always knew about? And yeah, get into that a little bit.
Sure. So DNRS stands for Dynamic Neural Retraining System, and it is a self led, drug free way to really retrain your brain that has been stuck in chronic stress patterns that are caused by limbic system impairment. This is specifically for limbic system impairment, also known as central sensitization. The limbic system is the part of the brain that is responsible for fight, flight, and freeze. And particularly when people go through trauma, it doesn't have to be trauma per se, but particularly people who have had trauma, our brains can get stuck in this fight, flight, or freeze response. And so neuroplasticity is a way to retrain the brain away from those patterns. And so it can shift into safety, regulation, and repair.
And how did you hear about this? Is it something you always knew about, or did you chance upon it, or online, or how did that happen?
Interestingly, my physician actually told me about it at the end of 2019. But because at that time, like I was going through so much and closing my practice, I glanced at it, but that was about all I did. And then as I was looking for more answers on how I could address the gut issues, because I still had some after pickle number two, not as bad, I was looking for other answers. And I happened organically to come across it again. And when I looked into it at the end of 2024, just like when I found the information about CCI, again, it made so much sense. And I gave it a try right away.
And so how did you do this? Did you go online? Did you talk to somebody? What was the process?
So because DNRS is self-led, what they do is offer training on how to do the practice. And so I went through their online training and then I implemented it myself, which is one of the things I actually really found empowering about DNRS is that there were no appointments I had to make. I didn't have to see anyone or rely on anybody else. I had no insurance claims to file. I healed myself.
And so is there some structure online that you went online and then you saw something and read it, or videos, or how did that work?
Sure. So their website is retrainingthebrain.com, and they do offer a 7-day free trial, which I took advantage of. And it's a series of videos, of training videos on how to actually implement the practice. And sadly, I can't go into the details of what that is. But it gave me an overview of what limbic system impairment is, and then started to get into really how to start to change my brain, how to rewire it. And I learned all of that just online at my own convenience, and then was able to apply it every single day for an hour a day for 9 consecutive months until I felt that my limbic system was healed.
And so what did you first start to notice? How did it progress over that 9 months?
I actually noticed changes pretty much instantly. I noticed that I literally had less tension in my neck and my upper back, my shoulder girdle. I felt lighter. And at one point, within a few months, there was one time I was walking around the neighborhood where I really noticed that it felt like I was seeing things through a new lens. And I actually got to talk with the creator of DNRS, Annie, and I mentioned this, and she goes, "Yeah, that was the same thing of like, it felt like I was looking through a new lens. It's like if you go to the eye doctor and they go, which is better, one or two,
Mhm.
as they're flipping through lenses. And it was like I got to see through that lens number two, which was a whole different experience. And gradually, my gut issues started to improve and the POTS symptoms began to improve because little did I know that POTS can also be caused by limbic system impairment. We know it's caused by CCI, but I had no idea that limbic system impairment could also be an underlying factor. And it really began to change other aspects of who I was, and other challenges like anxiety started to go away, depression started to go away, and I can tell you a whole lot more benefits if you want to hear them.
Yeah. So what patients are a good fit for this? How would you describe the perfect CCI patient who might say, maybe I should do something like this in addition to whatever else I'm doing?
Yeah, I would say those who could benefit from this. I mean, it is designed for people with limbic system impairment, which I didn't know I had until I started to look into this.
So who
But
are those people who describe a limbic system dysfunction patient so that people can say, maybe that's me?
yeah, most people who have limbic system impairment, as I mentioned earlier, do have experience with trauma of some sort, whether it's psychological trauma, physiological trauma, or both. Usually it's both. But they often come to DNRS with either unexplained or unresolved challenges like chronic pain, chronic fatigue syndrome, POTS, long COVID or other persistent or recurring infections, anxiety and or depression, to name some of those. And there is a list on the DNRS website of some of the things that people with limbic system impairment experience. So some of these things can seem completely unrelated to the nervous system at first thought. But really, when you dive into the science of how the brain works and how the nervous system works, it actually does make complete sense.
Gotcha. And it's my understanding that you were so impressed by all of this that you're now trying to work it into your professional life. So tell us about that. Where does that journey go for you here, as far as the next steps?
Thanks for asking. So I am a Duke Health trained health and well-being coach, and I'm almost complete with my coaching certification. And because I'm doing so well, I am embarking not only on working again, but also starting a new career and a new business. And having been disabled for the last 6 years, it feels amazing to actually be doing something meaningful and to be helping others again. And so, as mentioned, yeah, my former career is as a body worker and yoga instructor. And I was inspired so much by what I learned from DNRS. And I did a deep dive into neuroplasticity in general and have created my own embodied neuroscience based programs to help professional women on the edge of burnout so that they can regain energy, set stronger boundaries, make clear decisions, and have sustainable success in both their life and business. And I'm really excited for this next chapter.
And will you also see CCI patients in there, or is it going to be very focused on uh, life coaching professional women, or tell me about that?
Well, I think there are different possibilities. My focus will be on professional women, but I have, even in the last few months, connected with multiple CCI patients who, some of whom are doing DNRS at the moment, some who have done it, and had some really great conversations with them, and even really done some coaching with them too, just kind of on the side, just not professionally per se. And so I think there's a lot of opportunity to help both my demographic of professional women as well as people who have been through things like I have, because I certainly know that journey. And I also know what it's like to be on the other side and know I can help people also hopefully get to the other side of that too.
Yeah, I tell you, that would be incredibly valuable because I see a lot of CCI patients who there's the physical components of the problem, which can be awful. There's the symptoms that go with that, and then there's the reaction to the symptoms, which then kind of creates a whole other set of issues. And sometimes, as you've probably seen me talk about here, the reaction to the symptoms can also create some super bad decisions. Someone deciding, even though taking this branch would probably be a better idea because the reaction to the symptoms is so severe, they're going a different direction, which is ultimately not a great one. So someone who could do that and help patients through that would be an incredible benefit to the CCI community. So think about that.
I definitely will. Thank you.
Um, so, Jennifer, any last words that you have for CCI patients out there that are going through this because you've been through it? So give us some words of wisdom as a CCI patient who has this background, who did this type of retraining. What would you tell people?
I would say for me personally, the combination of both PICL and DNRS really was the golden ticket because I got both the structural and the nervous system support that I needed to be able to move forward with my life. Because they do go hand in hand, right? We're not separate from our bodies, we're not separate from our brains. We are one integrated system. And addressing both, I think, can give people the most benefit, especially because people have experienced medical trauma. We know medical trauma is a thing. And a
Yeah.
lot of people who come to your clinic, I know, have usually exhausted so many things. They are at the point where, like, this is for many of them, like, this is my last option because I have done everything else I can think of. And so if you're at that point, just know that there are ways to move your life forward. And there are things that you can do yourself to also enhance and to amplify that healing process. So it's a combination of seeking help from others, as well as knowing that you have so much power in your brain to also continue to heal your body.
Well, thank you uh, for those words of wisdom for CCI patients. Jennifer, thank you for being with us here this morning. And thank you for your time. I'm going to get to some of these questions that are building up here for me, but thank you.
Thank you so much.
Okay, so let's get back to questions here. I want to thank Jennifer for doing that because it's great to hear a CCI patient who's been through all of that, who obviously decided to go the PICL route, but also to add some other unique components that were very, very helpful. Let's see here. The one, is it the northern or southern clinic where you do your PICL? We only have one Colorado clinic. Back in the day, we had two, a South Denver one and a North Denver one. Maybe that's what you're talking about. But it's the North Denver main clinic where we do the PICL. DC suburb, curious about the efficacy of this intervention for CCI without having a PICL. Well, I think the good news is it's something that you can try without having to do a PICL, right? It's a self-directed thing. There's a DNRS website that you can go to and learn how to do their system. So it sounds like something you can do first, see if it really moves the needle. If it does, then great. If not, then obviously you can do both. Human being, is there a causal relation between concussion and ME/CFS? How is nervous system implicated in this? Yeah, so concussion is really, I think, one of the more interesting things out there because we have patients who get a bruise on the brain, if you will, or a concussion, but it's very hard to get significant head trauma without also getting upper neck trauma. But the problem is our medical care system pushes a concussion patient into this neurology pathway, and they go to concussion clinics and everything else. And oftentimes, because those aren't structural providers, they miss the upper neck component of concussion, which also interfaces with the diagnosis that we call ME/CFS. So is there a causal relationship between concussion and ME/CFS? Yes, and it's usually through the upper neck injury that goes undiagnosed. And I have to say, I'm on a couple of concussion threads. I don't participate, but I just watch them on Reddit. And it's fascinating to see that there's a large percentage of post-concussion patients with upper neck injuries, but they never get diagnosed or treated. Vera, hi, Dr. C. How long should the PRP injection flare-up last in ligaments? I had my AC ligaments injected 6 weeks ago, and it still hurts more than before the injection. Is this normal? It can be. That's not usual, but that could indicate some central sensitization. That could indicate higher levels of systemic inflammation for that patient. So those are some things to consider. It also is possible if you were taking some medications before the procedure. Frequently, we'll see that sometimes you need to restart some of those medications to sort of get a baseline to see where things are. But that would be a longer time period for soreness than would be typical. DC suburb. Maybe I am considering PICL, but worried because of my central sensitization. I developed a pretty severe inflammatory something with a flare-up of my symptoms after posterior PRP. I'm worried about my response to PICL. Yeah, so in those patients, we do that less is more approach. So for example, let's say we would normally do this amount of stuff with the average PICL on that person. We reduce it to that amount of stuff for the first procedure to get a sense of how the patient is going to respond. And then we can open up the throttle, if you will, for a second or subsequent treatment. And that seems to work pretty well to help patients through that big flare-up that comes with central sensitization. So that's usually how we approach that, and it works pretty well. M Purple 3000. What would the rationale be for not injecting asymptomatic arthritic facets in the lower neck? It's just all risk versus benefit, right? Medicine is one big risk versus medicine calculus. Everything we do in medicine, from giving you prescription medications to doing injections to doing surgery, carries a certain amount of risk. And so we try to mitigate that risk as much as possible. And when it comes to facet joints in the neck, if they're not symptomatic, they generally don't need to be treated. Now, could you treat joints that are minimally symptomatic that have arthritis? We do that with knees, for example, but a knee joint injection is a lower risk injection procedure than a cervical spine injection procedure. So again, it's just all risk versus benefit. Castle Girl. When you determine central sensitization, what do you look for? Yeah, patients that are centrally sensitized are pretty easy to identify. The first thing is they tend to have a huge flare-up with pretty much anything they do. So for example, getting a neck massage for a centrally sensitized patient might flare them up for a week or two. It's difficult to touch the skin or to put pressure on the areas that are injured or that feel pain. Doing a physical exam is difficult for those patients. Even just pressing on those spots can cause a substantial flare-up. So that's what a centrally sensitized patient looks like. And again, they're usually pretty easy to identify. Even if you can't identify them on exam, many times you can identify them just based on history, right? They're the patient that says, someone did some simple neck prolotherapy in my neck. It all went just fine during the procedure, but then I was flared up for 6 weeks. Now that's a completely abnormal response to simple neck prolotherapy. The traditional response would be maybe a couple days of soreness, that first night being the worst. So that's how you tell a centrally sensitized patient. Undercover sentinel. Dear Dr. C, HEDS, vascular TOS, and CCI, edema in arms is prominent, no DVT. Would you assess laxity in shoulder and clavicle area first, if protocol for a VTOS examination? Yeah, so I think what you're bringing up is that TOS, so thoracic outlet syndrome, is very common in patients who have craniocervical instability. And that's because the scalene muscles here act as sort of guy wires for this mast, if you will, of the cervical spine. And if the cervical spine is unstable, then the scalene muscles get very tight. The scalene muscles are the walls of the thoracic outlet. Now, the roof of the thoracic outlet is the clavicle. So as you bring up, if you're unstable in the SC joint or AC joint or both, then that can cause problems in the thoracic outlet, because again, that clavicle is the roof of the thoracic outlet, and the floor of the thoracic outlet are the ribs. And a rib that comes too high, for example, can cause issues. Now that's in the scalene triangle. You can also get thoracic outlet here in the pec. So do we have a vascular component to a TOS hands-on physical exam? The answer is yes. And again, big surgeries are usually not the answer in that clinical context. Normally, you treat the cause and see if the TOS goes away. And that's what I usually recommend. DC suburb, my cervical spine degenerative changes have accelerated after my CCI, and I've developed new onset cervical radiculopathy. I've already had one cervical epidural steroid injection and reluctant to have another for my right radiculopathy. While I'm considering PICL, please let me know if there are any other recommendations. Yeah, so it's pretty common that during a PICL procedure, we will treat obviously the upper neck components, but also the lower or mid neck. And we're not going to do that with high dose corticosteroids because high dose corticosteroids hurt the body and hurt the local tissues, including those nerves. So we're going to do that usually with platelet growth factors to try to help the nerves repair. But very common that we treat the high upper neck, mid and lower cervical spine at the same time. Blessed beyond, I go in spurts of feeling good, and then other times where I don't feel good at all. I have CCI. My question is, if I showed up for my EPICL and was feeling good at the time, would you still do the procedure? Yeah, so Blessed, I think the concept there is that we obviously need to look at someone as a whole, and that's going to be a whole over time. So if your history is, doctor, over the last 3 months, I've had, substantial period of time where I've been laying in bed, I can't do anything. There are other days where I feel better. Today is one of those days. Then obviously we're going to take that in context that you're mostly disabled, and that would qualify you for that EPICL procedure. But we certainly have patients that have really good days and they can manage during those really good days. And sometimes they come in during one of those really good days. So we're going to look at that over a longer period of time, not just on the particular day that you happen to show up to the clinic. Keep health. Dr. Centeno, what specific precautions or monitoring protocols do you recommend to protect patients with a known history of sleep apnea performing EPICL and posterior procedures? Yeah, so a large percentage of our CCI patients have mechanical or obstructive sleep apnea. I would say that it's probably half of our patients. So this is a super common one for us. So what do we do during the procedure? Obviously, the patient is monitored. Their pulse oximetry is monitored. In addition to that, we frequently do a ballet, if you will, with the CRNA handling the anesthesia, where our half of the team, myself and my assistant, are focused on maintaining that airway while we're doing the procedure, since we're working through the airway for that front part of an EPICL procedure. So it's pretty common that we manage that. Now, what does that look like? Well, if the patient's pulse oximetry drops, then we're doing a jaw thrust, we're doing what we need to manage the airway, bring that back up, then we do what we do. Now, realize that that's one of the reasons why you need to be highly trained in this EPICL, because you may only have a short window as the doctor in someone that has particularly bad airway to get a certain part of the procedure done. And obviously that takes a lot of experience and facility to be able to get that part done very quickly, so that you can work within the window that the patient's airway is supplying. And that's probably one of the more challenging things about this procedure, is that unlike other procedures where someone else is managing the airway, that's not your problem. You're working in the airway as the doctor. So it is your problem, and it is something that you're constantly managing in patients that have that issue. Now, we've got other patients where we don't need to deal with it at all, but it's pretty common for us to manage it actively during a procedure. Undercover Sentinel, how do you assess and diagnose laxity in hypermobile patient with vascular TOS? Bad posture may have created muscular compensation, overstretched ligaments plus bad posture. Can these trigger vascular TOS? Posture can make either neurologic or neurogenic TOS and or vascular TOS. Remember, these things all run together here, the nerve, artery, vein. Worse. So a forward head position, for example, is going to bring this forward and close down that thoracic outlet. So posture is a big component of treating any kind of thoracic outlet. Casian, what role, if any, does Regen Med have in healing diabetic foot ulcers or skin in general? Yeah, there's a number of different research articles on platelet-rich plasma, or PRP, in healing foot ulcers, in healing non-healing skin wounds, for example. So there's a big body of literature on that. And generally what it shows is that PRP does two things. PRP can stimulate wound healing, and it can also reduce the bioburden or the infectious burden. So PRP is antibiotic in of itself. So it's kind of got a twofold effect, both for repair, but also in killing any active bacteria in the wound, which is a big reason why many wounds fail to heal. Greg, research is finding more and more that neuroplasticity is a large part of healing along with fixing structural issues. It is for sure, and I think it matters more in some patients than others. And I think you're a patient who is right for this kind of neuroplasticity training if your reaction to what's going on is spiraling out of control. And everyone brings different levels of being able to tolerate and being able to flow with the punches. For example, some people are just born with the ability to do that, and others are not. So if you're struggling with your reaction to all of the different things that are happening to you in having CCI, the neuroplasticity retraining is definitely something I would consider. Brett, I know someone diagnosed with CCI2B who had severe autonomic symptoms and was basically bedbound. She didn't do structural treatments, instead focused on nervous system regulation and brain retraining, and now she's fully recovered. Does it suggest that someone can have structural findings like CCI but not actually be the root cause of their symptoms? How do you differentiate between the two? Certainly possible, Brett, to have a structural issue that isn't causing symptoms. Now, this brings up an important thing that I talk about a lot, and that is that we have two different things here, right? We've got the instability, and then we've got the symptoms. Frequently, the symptoms are generated by irritated nerves, irritated joints, and we have seen situations where we've fixed the instability and the symptoms remain, and we've seen situations that go the other direction as well. So usually they tend to correlate, but they don't always correlate. And that's one of the difficulties of being a doctor, right? What you're trying to do for me with this procedure is to look at all the parts and pieces to say, yes, this person does have craniocervical instability based on imaging metrics. Yes, the symptoms seem to fit that. Yes, the things that I would expect to make those symptoms worse or better are there. And all of that has to line up for us to say, yes, this is probably a good idea to proceed with this type of treatment. Having said that, if any one of my patients wants to say, well, I'm going to try this neuroplasticity stuff first and see if that gets me where I need to go, that's fantastic, because the least invasive thing that's the most likely to help is the right next step. Undercover Sentinel. For HEDS, vascular TOS, and CCI, what device do you recommend to avoid reconditioning and move lymphatic system? None of that. Not quite sure of the question. Again, we're going to focus on the causes for the problem and treat those causes. Now, as far as whether or not vibration plates might be helpful, sure, I would certainly give that a try. Most of our patients who have CCI aren't going to tolerate a stationary bike. Most of our patients who have CCI aren't going to tolerate an elliptical, and almost 0% of my patients would tolerate Pilates. Casey, why is academia so absent in the regen world? I don't know that it's so absent, just that it, like many things, it tends to be underrepresented. Having said that, there isn't an academic institution in the United States that I know of that doesn't offer regen med at this point, meaning that you can get a PRP injection now at Harvard, you can get a PRP injection at Yale, you can get a PRP injection at Duke, you can get a PRP injection at Stanford. All of those places now offer Regen Med, because Regen Med has gone from very fringe to much more mainstream. What you can't do is get it covered under insurance, but all of those places offer it. So there's this gap between it now being accepted by major institutions and insurance coverage. Those are two different things, though. So I think a lot of patients sometimes confuse insurance coverage with acceptance by large universities. Regrettably, those are two things that, in this case, Venn diagrams that don't cross each other. Undercover Sentinel, for CCI patients after PICL or any orthobiologics treatments with you, do you recommend continuing an engineering profession that demands 8 to 9 hours in front of a computer? That would have to be determined by your treating doctor and yourself. If you believe that those sorts of activities are causing you problems, then the recommendation would probably be to back off of those things for a while. Now, having said that, we also have to work with the reality on the ground of what's occurring with the patient. So, for example, we might have a patient who says, I work for X company, this is expected at X company. For instance, I've got a patient that's an Apple employee, right? Apple employees, from what he has told me, are expected to get there early and to leave very late every single day. In fact, if they don't, then that's a problem. So obviously, we've had to work within his schedule and try to do what we can do. Let's see here. Let's see, I'm just trying to get some questions that are more applicable here. Greg, Primal Trust is a great program for nervous system retraining and rewiring. I recently started before PICL in this April. Already feel some differences, I believe will complement healing process. Good to know, Greg, and anyone else that has a neuroplasticity program. There are lots within physical therapy as well that they've tried. Please throw that in here. I'd be happy to talk about it and bring that to light. My goal with this particular Facebook Live this morning was to open the door on this stuff and to try to let some of our patients know not only about DNRS, but also sounds like Primal Trust. There's a couple through physical therapy as well, in order to open the discussion on this kind of care. Brett also wanted to say thank you for talking about nervous system work, Dr. C. I think anyone that goes through the hell of CCI would benefit from some form of nervous system work. I agree, Brett. DC suburb sounds like a trauma-based cognitive behavioral therapy intervention. Yeah, I would think that it does. There's obviously other trauma-based interventions, EMDR being one that goes through a little different pathway, but it's a similar concept, right? Undercover Sentinel, Dr. C, vascular TOS for Doppler ultrasound. Shows significant fibrosis in PEC minor and same with scalenes. What would you do? Would you start with Botox or too bad for CCI? You don't really see fibrosis on Doppler ultrasound, so not quite sure that makes sense in context. What you would see in a Doppler ultrasound in a vascular TOS patient is decrease in flow, usually with specific maneuvers, but you don't really get the other part of the information that you're discussing here. I think, as I've said on the Reddit thread about this, and I've answered this before, muscles tend to hypertrophy or get bigger when they have more loads placed on them. And so if we're talking about scalenes or PEC, then that can cause issues in this particular setting, but the treatment is not to artificially paralyze that muscle, which would be Botox. The treatment is to figure out why that's happening and treat that cause. Aaron, how would thoracic outlet be treated by injections? Two different ways. Again, getting back to treating the cause of the thoracic outlet. So I'll give you a great example from this last week, right? Patient came in, one of their main complaints outside of their CCI stuff was thoracic outlet. Nobody in, I don't know, 5 or 10 years of looking at the thoracic outlet component had ever noticed that that particular person had an unstable clavicle. Their SC joint was unstable, their AC joint was unstable. That's the roof of the thoracic outlet. So if these joints are unstable, that roof is banging on the brachial plexus and causing all the thoracic outlet issues down the arm. So in addition to treating the CCI, which could be a cause through the scalenes that we've already discussed here this morning, we tightened down the ligaments at the AC and the SC joint in order to reduce that constant beat up and that extra motion in the roof of the thoracic outlet. So that's a good example of how injections often fix thoracic outlet. You can also do platelet powder dissection into the thoracic outlet as well at the brachial plexus. So lots of different ways to treat that. And I would say that 90% of the thoracic outlet that I've treated through the years just goes away with proper injection therapy. Problem is, most people never get access to that. The only thing they're really offered is surgery. Cassian, do you utilize any treatment suggested by Liftoff's work? Less so. So just so that people understand what we're talking about here, there's a type of neural therapy where you treat small little nerves that come through fascial planes, and that's called liftoff or a liftoff technique. And we've used it through the years. In fact, I just used it, well, probably a month ago. So when I believe it's important to use, I will use it. Having said that, liftoff was never really trained in any of the stuff that occurs deeper. So his approach was always to look at fascia, but he didn't understand how to do anything with the facets. He didn't understand how to do anything with the base spinal nerves. That just wasn't his training. He didn't have the ability to do those injection procedures. So everything was fascia. So I think approaching that fascial issue, especially fascia nerve issue, can be very important in the right patients. But oftentimes it's treating deeper structures that liftoff just didn't have the training to address. Let's see here. Pink fur, back pain, PRP, or stem cells. Depends on what's causing the back pain, right? Back pain isn't really one thing. Back pain is a collection of about at least a dozen, if not 24 different diagnoses. So each of those diagnoses would map to specific treatments of specific structures under very advanced focused imaging guidance using either PRP or stem cells. So for example, if you had a problem with a mild bulging disc and an irritated nerve, that might be platelet lysate or platelet growth factors under X-ray guidance with contrast confirmation in a transforaminal injection. That being completely different than if you had a facet joint problem, which would be high-dose leukocyte-poor PRP injected directly into that facet joint. So as you can see, both of those things cause back pain, but the treatments are completely different. It's been advanced by Harry Winston. Are there locations for this type of treatment in the UK? You know, there probably are, but I'm going to guess that the UK is going to be underrepresented in some of these things, like Europe tends to be underrepresented in some of these things. You know, listen, one of the downsides of the US medical care system is that it's incredibly expensive. But one of the upsides is with that additional money in our system, and it's probably 10x the money in the European healthcare system, comes lots and lots and lots of different options. You've got a smorgasbord here of different options in the States that you just don't have in Europe. And that's because there's far less money in the European healthcare system. That's good, right? They're probably in many cases for many diseases treating things more efficiently than we do here in the United States. The downside, however, is that your choice is extremely limited in Europe relative to the United States. Robert, I think the answer to that question was 2, and I think it was primarily DNRS. Undercover sentinel for women with hypermobility or HEDS, the hormonal change seems to play a role when reaching 50. What do you do with excessive fat developing without diabetes, normal thyroid, what to do with the weight? So the single biggest thing as women get to perimenopause is bioidentical hormone replacement. Now that's not going to your OBGYN and getting estrogen. That is seeing a longevity specialist who focuses on the use of estrogen, progesterone, testosterone, and other things, and does blood tests 6 times a year to balance those things in those women. It's an incredible thing. It tends to keep that visceral fat load down by quite a bit, but it's also expensive, right? It's something that isn't covered by insurance. You've got to see these folks out of pocket. You've usually got to buy these treatments and these blood tests out of pocket, but it's incredibly effective. The women in my life I know who do this tend to solve the issues you're talking about because their hormones never go out of whack. They're maintained at all times. And it's not going to your OBGYN for some estrogen patches or pills. Let's see. DC suburb. I am quite worried about 6-month healing period after 1 PICL. How many days should NSAIDs be avoided? How is pain managed after the procedure? You've got to be off NSAIDs for at least a couple of weeks before and at least a couple of weeks after. It would be ideal if you were off NSAIDs altogether, but we do have patients who are NSAID dependent, addicted, whatever term is appropriate there. And in those patients, we'll usually keep them off for a couple of weeks before, maybe 3 or 4 weeks after, and then restart at that point after the acute inflammatory response is done. And then pain managed after the procedure, just describe one of those. But obviously, for acute pain management, we have patients who take narcotics or non-narcotic pain relievers. Then after a few days, they're off of those onto over-the-counter things like Tylenol. But again, when it comes to restarting nonsteroidal anti-inflammatory drugs, that gets pushed out because those drugs tend to mess with that acute inflammatory response that we need. Recommendations for IPA-PT or any PT program in Atlanta for CCI. I don't have any specific recommendations for physical therapy providers in Atlanta. Okay, we're getting towards the end of our time here. Let me try to go through these questions. Again, I wish to get more questions than I've got time to answer. PICC for a treatment for symptomatic thoracic small bulge pain. Usually that's a thoracic transforaminal epidural, so X-ray guided procedure with contrast confirmation. It's an advanced procedure because of the lung field, so oftentimes it's not done. I've done thousands of them. We use platelet growth factors to do that. It works pretty well. Let's see. trying to get to some interesting questions here that you guys haven't seen. Pink fur, if someone has had an epidural injection, how long do they wait before they get a regenerative treatment? If the epidural was done with high-dose corticosteroids, as it usually is, then you're going to want to wait at least 6 to 12 weeks before you get a regenerative treatment. DO7, do you typically do PRP only for upper cervical facet joints and then do PRP with stem cells for second PICL if first PICL was tolerated well? When doing other joints like shoulders, that both PRP and stem cells. So normally for facet joints at the first treatment, we'll only do PRP. If someone tolerates that and it's a breeze, then we can certainly add in stem cells into those joints at a subsequent treatment. When it comes to other things like shoulder, oftentimes that's using the extra stem cells or extra bone marrow concentrate. Again, just trying to get to some questions here since we've run out of time that would be interesting to see. Carol, hi, Dr. C. When would a stellate ganglion block be a good choice for treatment? If the subject already has been covered, please forgive me, I haven't been online the whole session. Stellate ganglion blocks, just so that people understand them, can be good for patients with trauma in that chronic fight or flight. So a stellate ganglion block would be a physical treatment that could complement what we're talking about here today, this limbic system overdrive, or being locked into that chronic fight or flight response. Now, the downside of a stellate ganglion block is that it's one of the few blocks that are done in a physician's office where you have to have a crash cart at the ready to be able to resuscitate the patient. And so the answer is why? Well, because you're using anesthetic close to the phrenic nerve and or close to nerves that can bottom out the patient's blood pressure, you've got to have the ability to resuscitate the patient. And regrettably, I think that probably is only the case in about half the clinics where SGBs are done these days. Half the clinics would have no problem resuscitating the patient. If there was an issue, half the patients would probably struggle, or half the clinics would probably struggle. So for that reason, stellate ganglion block isn't in my first choice list because it's a high risk injection. Now, having said that, when we do vagus nerve treatment, we're also frequently treating the stellate ganglion with those platelet growth factors without anesthetic. So there isn't a need to be concerned about the patient coding as part of the block. So just realize that stellate ganglion block, now done widely, lots of people, really done first for this application in PTSD by Sean Mulvaney, good friend of mine. And I think as Sean would agree with me that they're being done in lots of clinics now where they shouldn't be done because of that coding issue. So be very, very careful there. Okay, guys, let's try to get to one or two more questions here. Castlegar, we banked our daughter's cord blood at birth as something she might be using a PICL sometime in the future. No, that would be illegal to do today. This is a little bit of a scam, right? The whole cord blood banking thing, because on the one hand, this is pushed very aggressively in OBGYN offices, and lots of parents do this, but there are no FDA-approved indications for the cord blood outside of cancer care. So it's kind of like buying an expensive insurance policy and continuing to pay an annual basis for this insurance policy that won't pay off unless you've got one very, very specific rare problem. So it wouldn't be legal for you to show up to my office to use your daughter's cord blood in this procedure. because there is no FDA-approved indication, and that cord blood would be considered an unapproved drug product. So I know that sounds a little weird, and it sounds different than what you were probably told by the people that got you to bank it, where your daughter can use that without any question now, as she can use it in the case where she had a rare blood cancer that can be used that way. But outside of that, there is no FDA approved indication. So again, it's a little bit like paying for an insurance policy that can never pay off. Nathan, do you do the same hands-on exam for each procedure? I think I forgot to mention something the first round. Hands-on exam is determined by the history. So if we're dealing with a classic classic CCI patient, then it's usually a very similar hands-on exam. But then, many patients add in, oh, can you take a look at my shoulder? Can you take a look at my upper back, etc. So obviously that changes the exam. Okay, guys, I think we are done. I'm coming to the end of the hour. So do me a favor, if you haven't already, give me a like, share, comment, subscribe. I want to thank Jennifer for being with us today. I think she kind of opened the door to this neuroplasticity concept. There are lots of different types of treatment that are neuroplasticity based. There's the kind that she discussed, DNRS. There's another type that another patient brought up today. There are several different types of cognitive behavioral therapy out there, including many in physical therapy. But I think they're all very helpful in dealing with that chronic fight or flight type patient. And this is something that can be very important in CCI patients, right? We're all built differently. Some of us can go through amazing amounts of trauma and it just slides off your back. Others, not so much. And so for those patients, this can be an important way to regain control of that limbic system, that fight or flight system. So something to think about. And many times you can do these things through online programs. So I would highly encourage you to do that. If it gets rid of your problem, then maybe you don't need to see me, and that's always the best thing. Okay, guys, thank you so much for spending time this morning asking all these great questions. There are no bad questions. And I will be here, I think, next weekend to do another one of these on another topic. So thanks so much and have a great weekend and have a great week.